Hello, my name is Guillermo Garcia-Manero from the Department of Leukemia at the University of Texas MD Anderson Cancer Center. I'm very happy to be doing this presentation. I am the past president of SOHO, and I think this is one of the first kind of interviews that we're doing through SOHO Insider, so this is really interesting and great news. And I'm going to use this opportunity to give you an update on what we saw with the results of the COMMANDS trial and with luspatercept in general. So as the audience very well knows, we developed luspatercept, a TGF-beta inhibitor, first for erythropoiesis anemia as a second-line drug that led to this medalist trial that led to the approval of this drug for that group of patients. And then based on the activity and safety profile of this compound, then we developed this COMMAND study. This is actually a very important phase 3 trial where we compare luspatercept versus epoetin alpha in first-line low-risk transfusion-dependent patients with myelodysplastic syndrome. That study was presented a couple of years ago at ASCO, plenary at EHA, again at ASH, published in Lancet, and it led to the approval of this drug in first-line. At ASH last year, actually 12 months exactly, we were presenting the first update of this trial, looking basically the pre-planned analysis around 12 months. But this year, actually, we are starting to see actually mature data from the trial. And I had the opportunity on Saturday at the ASH meeting to present the update now that we are actually crossing 1.5 years. So we were looking at the quality, the duration of responses, both in luspatercept and ESA for those patients that are now over 1.5 years. And what we see actually is that those responses are maintained in around a third of the patients that were on the study. So this is actually very good data, right? Because the response rate was the first take around 70%, and then the first year dropped a little to 50, and now we're seeing it around 30 a year and a half after initiating this therapy. These are really striking numbers. We did a subset analysis looking at the specific groups that may or may not benefit from this kind of long-term responses or transfusion dependency with this compound. And we saw something interesting that I think could help us decide how to use this compound in first line. That is, patients with a low EPO level, let's say less than 200, actually benefited the most and were the ones who actually were really achieving or developing these long-term responses, in addition of being RS positive or CEP3B1 mutated. Why I think this is important is basically it shows that perhaps those patients with more benign features that some colleagues or investigators have suggested could benefit from the old standard of care really do much better if you start luspatercept up front. The other important issue from this update is the toxicity profile. We wanted to see if there were new emerging toxicities in one arm versus the other, and we didn't see that. Actually, they remain virtually identical between epoetin alpha and luspatercept. And finally, really, really critical, the development of high-risk myelodysplastic syndrome or acute myelogenous leukemia as transformation events in these patients now that we have actually significant follow-up. And we didn't see that either. Actually, they were totally neutral, and if anything, actually a little bit lower for those patients on luspatercept. So in summary, after 1 year and a half, we see that a third of the patients are still responding to therapy. And remember, response is transfusion dependency plus an increase on hemoglobin of 1.5 grams. Those responses are significantly more durable with lower kind of interval transfusions needed through that period of time, similar toxicity profile, and no increased risk of transformation. So I think that this really validates the original results of COMMANDS, suggesting or indicating that luspatercept is our first-line agent. So it's really important times. We saw actually at the meeting quite a bit of interesting data in the context of lower risk disease. Investigators are now talking about higher doses of this compound, combination studies. French are doing a study called Combola, combining it with ESAs. And we're starting to learn a little bit more in terms of mechanism of action of this drug. And something that is starting to permeate, just to close this presentation, that I find intriguing, is that through the COMMANDS trial, we are starting to see data from gene expression assays and proteomic assays, suggesting actually that luspatercept is not only an erythropoiesis maturating agent, meaning like affecting erythropoiesis per se, but it's actually modulating inflammatory pathways, innate immunity alterations, and actually modifying proteins that are involved in cardiac remodeling. So it's possible actually that this class of compounds may have other effects beyond what we see in hematopoiesis. So really interesting moment right now for the evaluation of this compound for our patients with low-risk MDS. Thank you for your attention.